Questions from Tuesday's lecture? Nothing at all. Okay. All right. So we were talking about paralysis. And so there are several problems, obviously, with having long-term paralysis on your patients. You don't obviously do this for long-term in the ER, but this is like when patients get moved up to the ICU setting. You'll see this use. And so the most common reason why you might do chronic paralyzation for these patients is going to be synchronization with the vent. So obviously if they are moving around or if they're very uncomfortable. And so I was kind of talking about this with one of your classmates the other day, but when I was on rotations, we actually got to rotate around with a respiratory technician for one day, and one of the things they did is they took us back to their RT dungeon, and they had a ventilator that was there, and he gave us a mouthpiece and actually put us on the mouthpiece so we could actually feel what the positive pressure of ventilation feels like, and it was super uncomfortable. I did not like this thing breathing for me, and I could imagine if I was having to be on a ventilator, I would probably be fighting that ventilator, right? So we combat that by using lots of sedation. We use analgesics usually opioids with a benzodiazepine to sedate the patients, right? So they can be a little bit more kind of calm and synchronized with it. But if that's not working, then you have to use a paralytic, right? So basically just stop them from moving whatsoever, and you're breathing for them. So that could be one case. Sometimes we'll do it for patients who have head traumas or things like that, or have any kind of issues with intracranial pressure. That can be another one, because obviously if they are moving around or if they're kind of bearing down, that can increase ICP, so that can be one reason to do it. Do you guys know where we might use therapeutic hypothermia? There's drownings. Usually after cardiac arrest is probably the biggest thing where we have the most evidence for it is using this therapeutic hypothermia. Basically, a patient comes in, if it was like I can't remember if it's like witness VFib, VTAC out in the field, they'll come in, they'll get resuscitated, hopefully, and then they will cool them down, right? And so one of the big things that can kind of combat that is your body, when it gets cold, it wants to shiver, right? Because that generates heat. So we can actually use paralytics to prevent that from occurring for those patients, to help keep their temperature down. So that's one thing you may see being used for. And then if you need to facilitate a procedure or something where you don't want the patient moving at all, paralytic can be used there. But there are complications with the longer term time frame you have the paralytics on board. You have things like VTE that can develop, right? So how can we combat VTEs from developing for these patients? Yeah, we can use heparins. We can use our low molecular weight heparins as well. It's another thing, non-chemical.
SCDs.
Yeah, SCDs, so sequential compression devices. So you'll find a lot of patients end up being on those. And that's actually one of the big things that you monitor for, especially in ICU patients, because again, if they have an in-hospital VTE, one, that's really bad for the patient. It's very expensive to treat that, and then you don't really get reimbursed in a lot of cases for that because of the fact that you did it to them, right? Or you put them in a state where they were more at risk for it. So that's one thing you want to look for. Obviously, ventilator-acquired pneumonias, if they're not really able to manage their own airway, you have a big tube in there, you're going to have more risk for bacteria to translocate. That can be one issue. These patients are in really high stress states. You can see gastric ulcers develop, so oftentimes they're on either Zantac or proton pump inhibitors. One other thing you may not think about is also corneal abrasions, because as patients, if they're paralyzed, can they blink? No, right? So you worry about them having dry eye, so oftentimes you'll find orders for artificial tears, some kind of eye lubricant, so that way they can make sure the eyes don't dry out and they get any kind of abrasions there. And then we talk about this ICU neuropathy, so you can end up seeing.
Excuse me, no mean to interrupt. Okay.
Now that we're back from our musical parking spaces. So the other thing you can see with long-term paralysis is this idea of ICU neuropathies that can happen. Sorry, guys, I thought everyone's back, but should be the last one. So it's ICU neuropathy. Essentially what you can find is that some of these drugs actually end up sticking around for a lot longer than what you would expect based on tissue levels building up and things like that. So you may turn off the paralytic, and even though it's a fairly short-acting one, you may find that the patient has kind of a prolonged duration of action. It may take a while for them to actually be able to kind of breathe back on their own. They can have kind of lasting kind of paresthesias and things like that that will persist for some days to weeks afterwards. So just be careful with that. And again, this is all reasons why we want to use as short a term of paralysis as possible. So how do we actually monitor the effects of our paralytics? Have you guys ever seen this this train of 4 device? Ever heard of it? Okay, so basically what this thing is a device that tells us just how paralyzed a person is. So you can see here the device here, and it has 2 electrodes that will connect to it. So there's a few different places you can put it, but usually the ulnar nerve is going to be the most common one, or the most common place that it is put. You'll also find this device, and it'll have like 2 little metal prongs on it that can be done for the same thing. So instead of having like sticky electrodes, you can just have these 2 little prongs. And so basically what it does is it'll send out 4 electrical signals that should activate the nerve if you have no paralysis going on, right? So if those muscles are still working, they're still responsive to these electrical signals, you should see the thumb twitch, okay? And so you can actually determine how many twitches you see, how many of those receptors are being blocked. Remember, what type of receptors are we blocking with the paralytics? Acetylcholine. Which type of acetylcholine receptors? The nicotinic receptors, right? Because we're blocking those skeletal nicotinic receptors, not the muscarinic. Otherwise, we'd be seeing, the anticholinergic effects. We're not seeing that. We're just seeing blockade of those nicotinic receptors. But anyway, so you can determine kind of how paralyzed a person is. And so if they have 4 twitches, then they either have 0 to say like 75% of those receptors are being blocked, right? If you only see 3 twitches, that could mean around 75% are being blocked. Obviously, 2 switches, even more, so like about 80% of those receptors. And then 1 twitch, 90%. If you see 0 twitches, that means the patient is very, very paralyzed, and they have 100% of those receptors blocked. So do you need the person to be 100% paralyzed? Most often not. Most of the time you can get away with usually 1 to 2 twitches is usually a pretty good level of paralysis. And again, you're dialing back your continuous infusion to kind of get that goal, right? So sometimes you may need to dial back your dose, sometimes you may need to give more. But this is one of the ways we look to see to make sure our patients are not too paralyzed, because again, you're increasing your risk for things like those neuropathies that show up over time and whatnot. So it's kind of cool if you ever get to see that. Nurses will have orders to do this occasionally while patients are on their paralytics to make sure they don't get too overly paralyzed. Okay, so going back to talking about the rapid sequence intubations, what happens if the intubation does not go as planned? Because again, this is usually if you're doing it in the ER, this is an emergent type of procedure. Sometimes you can have bad airways, especially with some of our pediatric patients who come in with kind of congenital issues. Some of them, have developmental issues. And so a lot of times you can find that their airway is very, very difficult to get into. Some adult patients, especially if they have you guys will go through the assessment of the airway, but some patients are just going to have really bad airways, either due to trauma or due to their own kind of physical layout. And so you have to remember that things do not go as planned. You need to think about when to give medications again. You mentioned that the drugs that we're using, especially like etomidate and succinylcholine, don't last forever, usually around 5 to 10 minutes or so. So it's not uncommon to where if you were to have, say, like a failed attempt or two at the intubation, you can start to see the patient start to move around some more. And that can be another good sign that you want to go ahead and give them more drugs in order to help get them paralyzed and sedated again. But again, remember, you don't want to just give the paralytic by itself. You do want to give that sedative along with it, because again, you don't want a paralyzed patient without any sedation on board. It'd be pretty terrible. So again, 5 to 10 minute mark is usually when you want to consider that second dose. So again, remember that there are different drugs that are available, especially for those induction agents, and which one's going to be better for different patients. So if you have like a status asthmaticus patient, like which drug might be better for them? Okay. Not paralytics, but the actual induction sedative agents. Yeah, ketamine's a good one, right? Because that's a bronchodilator effect, right? So that's a good one. If the patient has, say, increased ICP, which could be good for them. You have a couple options, so things like propofol would be okay, things like Versed would be okay, etomidate would be okay. Probably wouldn't want to use ketamine in that situation because that can actually have a risk for increasing ICP, right? So kind of think about those situations and what drugs you might want to use, and think about the fact you might be making these decisions in very kind of a quick succession of events, right? So you want to think about the contraindications and be able to kind of identify what's better for your patient and what's not. And remember the contraindications for getting succinylcholine, things like 48 to 72 hours after like a crush injury or burn injury. And remember that like your non-depolarizing neuromuscular blockers lack a lot of those contraindications, usually much safer, and you can kind of give them to pretty much any patient. But a lot of the factors that go into it, again, patient history is the #1 thing, but you'll find that provider preference and comfort is usually going to be the other thing. For instance, with some of my docs in the ER, they always like to use Versed, right? That's just the sedative agent that this one particular provider liked to use. On the other hand, we have a lot of newer providers who had just finished up their fellowships and they're coming out and they've never used succinylcholine, only ever used rocuronium, and so that's just their preference. So you'll find that it's going to just depend a lot on who the provider is and what the patient history is. Question on RSI, intubations, or okay. So moving on, we'll talk about ACLs, which stands for Advanced Cardiac Life Support. So this is when your patient has no heartbeat, has no perfusion. What are we going to do for them? Does anyone know what we're going to do for them? Lots of CPR, right? We're going to find that drugs are not going to be super useful in a lot of situations for ACLS. Not a ton of evidence to show that the drugs that we give are super useful, especially in cases of actual cardiac arrest. We'll talk about bradycardia and tachycardia, and that's going to be much more medication focused. But you'll find that really good CPR is like the #1 thing that's going to be helping these patients out, right? So some of the meds we're going to cover, kind of go through this list. Some of them we've already talked about before, but we'll mention them here in this particular situation, and then we'll kind of look at the guidelines, the ACLS algorithms, and kind of how they've changed over time, how they've kind of been streamlined to where it's much easier to do nowadays. You don't have to really consider as many drug options. We'll kind of look at what our options are going to be in that situation. So one of the things that you may not realize, and I remember the first time I ever had to participate in a code in the hospital, if you were the one getting medications ready, which you may or may not be tasked with doing, depending on what the situation is, you open up like your Atropine here, and if you're lucky, you open up on the right side of the box. Because these things are really meant, there's a side that says open on it and a side that does not. If you open it from the wrong side of the box, the meds actually don't come out of it because it's like designed to only open up from that open side. Anywho, so what you end up getting out is this this kind of barrel here with the needle end on it, and then you have this like vial of drug. And so you're like, okay, well, how do I get this drug out of here? What do I do? Right? And so if you're doing it the first time, it's in the middle of a code, like you're going to be kind of freaked out and not really know what the heck you're doing. But these are called Bristojets, and so it's a very common way you'll see a lot of code medications being given. Essentially, you're just going to pop off the yellow caps on either end. It's really important you do that, otherwise nothing's going to make contact. And then there's actually a needle here in this barrel, and it will go through this rubber stopper here, and it'll actually make contact with the drug, and then you can push, basically just push it right out. So the two connect together, they screw in, and then you just push it, and you're good to go, right? So obviously, you know, we're dealing with pediatric patients. The full vial might not be a good dose for them, right? So a lot of times you either have to use things like stopcocks or other syringe connectors in order to get smaller doses out of it. But usually for adult patients, this is going to be kind of a single serve dose. You just go ahead and push the whole thing for them. Okay. Also, these vials are usually glass, so if you drop them, they're going to end up breaking, and you feel very dumb for doing that in the middle of a code, right? Not that I've ever done that, but just saying it could happen. But again, yeah, make sure you remove those yellow caps, screw it together, and then you can just go ahead and push it. So it's very quick, easy to get it going. But again, with pediatric doses, a lot of times you're having to draw smaller doses out of that in order to make sure you're giving the right dose to the patient. Because obviously, doing a PEDS code is going to be a lot different as far as doses go than the adult code. So we'll first start out by talking about our bradycardia. So again, obviously a heart rate less than 60 would be pretty common. One of the main drugs we're going to use to treat bradycardia is going to be our epinephrine. Obviously, this is an endogenous catecholamine. Our body produces a lot of epinephrine already, and this is going to be working mainly by stimulating both alpha and beta receptors, right? So if I activate the beta-1 receptors, what's that going to do for me? Increases contractility, increases it's a positive chronotrope, so you're going to have faster heart rate, right? So that's hopefully what we're going to be doing here. And then alpha stimulation does what? Alpha-1 stimulation. Vasoconstriction, right? So it's called vasoconstriction, so you increase your systemic vascular resistance. So if they're hypotensive, this will also be useful for that as well. But when we're giving epinephrine, it's primarily going to be for those beta-1 effects in order to help speed up the heart rate. But also secondary to this, you're increasing coronary perfusion, which is probably going to be important for those patients. And so typically the biggest indications we're going to use for epinephrine, and this is in the code setting, this is the #1 drug you're going to end up giving. You're going to use this for symptomatic bradycardia. So again, if they have a heart rate less than 60, with poor perfusion, you know, so if they have, you know, kind of cold extremities, poor cap refill, things like that, you're seeing that would be an indication to use epinephrine. And then if they're in cardiac arrest, right? So you can give this for VFib, VTAC. If they're in asystole or PEA, this is the #1 drug you're going to be giving. You guys know how often you give it. Every 2 to 3 minutes. So you're going to find that a lot of the algorithms are going to come back to this, that you're giving it every 2 to 3 minutes. A lot of things in CPR are going to be done in 2-minute increments, right? So you're doing pulse checks every 2 minutes or so. You know, you are giving your epinephrine every 2 to 3 minutes. So you're going to find this kind of a common time interval when you're doing codes. I'm going to include the doses here, but you don't need to necessarily memorize those for our purposes, but just I'll kind of make some points when we're kind of comparing things. Usually the doses for an adult patient, if you're pushing it in the middle of a code, is just going to be 1 milligram, right? So, and the nice thing about those Bristojet packs is they come as a 1 milligram, basically it's a 10 ml vial essentially that has 1 milligram of drug in it. One of the things you'll see, especially with old nomenclature, is that a lot of epinephrine used to be talked about in concentrations of 1 to 10,000, 1 to 1,000. Do you guys know what that means? Close, yeah. So it's basically 1 gram per every, say, 10,000 mLs, right? So 1 gram in 10 liters of drug. So does that really kind of help you out when you're trying to think about how to get a dose out of this? It doesn't, right? And there's also been lots of medication errors, because usually in code cards, what you'll find is you'll have those kind of pre-done vials where they have 10 mLs of the 1 to 10,000 solution, which is 1 milligram for that, which is usually what you want to push in a code. But they'll also find there's a vial of 1 to 1,000 epinephrine, a 30 ml vial in that, and so that's actually 10 times more concentrated. Basically, it's going to be 1 milligram per ml. I'll show you a trick to how to figure that out. But there's medical errors where they were goofing it up and using the wrong concentration. And if I give way too much epinephrine, what do you think it's going to do? Way too much vasoconstriction can cause intracranial hemorrhages. It can cause ischemia to different tissues, especially to the heart. Lots of problems. So there's been deaths associated with giving the wrong concentration of epinephrine. So one of the big things they've done is they've actually taken away this nomenclature. So you probably won't see this when you get actually out there in rotations. But if you ever hear someone say, "Oh, give me epinephrine 1 to 10,000, 1 to 1,000," this is what they're referring back to. The trick that I use to remember what the concentration is if I see 1 to 10,000, I know there's 1 milligram in 10 mLs of solution. If it's 1 to 1,000, I know it's 1 milligram in 1 ml of solution. If it's 1 to 100,000, it's 1 milligram in 100 mLs, right? So that's usually kind of easy way I use to remember what the concentration actually is for those drugs. But anyway, usually you're going to see your max dose is 1 milligram, so that's usual max dose for an adult patient. You can see here for peds patients, we're giving usually quite a bit less, so about 0.01 mg per kilo. So if you don't have IV access, what other routes can we give the drug by? You can give it by IO, right? That could be one way we do it. What else could we do? You do like a Pulp Fiction thing where you do it, right?
Why not?
I've never seen that done. I don't know if, can't say I've ever seen it, but who's to say it doesn't happen elsewhere? You can give some of these drugs via the ET tube, right? So this could be a way, if you did not have an IO kit, if you did not have IV access, you could actually give some of these drugs via the ET tube. And so there's an acronym I'll show you in just a second that kind of shows the drugs that you can commonly do that. It's kind of just a point of more trivia at this point than anything else, but it's good to know what drugs you can give via the ET tube if you did not have access. Again, rarely done. Usually most places have IO access available nowadays. So if you can't get an IV, you can just put an IO in, and again, that's a big non-collapsible vein. Get very good IV access at that point. But you'll notice here that the dose we're given for epi through the ET tube route is going to be much larger than you see for the IV route, right? Because our bioavailability is not going to be as good when you give it via the ET tube, so you need to give a bigger dose to make sure they actually have absorption of about 1 milligrams worth of drug. Again, just a quick way I remember this, if I see 1 to 1,000, I know it's 1 milligram in 1 ml of solution versus 1 to 10,000, 1 milligram in 10 mLs of solution. I actually almost had a big error that happened when I was in fellowship. Remember, I was in the emergency department. We were having a code ready to come in. The patient had been coded for a while, finally got pulse back. They wanted to put the patient on an epi drip. And so, instead of having the pharmacy make it, over in the basement and then send it over to you, you have the stuff in the code cart. It's already available to make your own epi drip, right? And so there was 2 nurses that were attempting to make this. And basically the one nurse said to the other one, "Okay, I just used this whole thing to make the epi drip." And nurse B thought she was referring to that 10 ml syringe of the 1 to 10,000 solution. She said, "Yeah, go ahead and use that." What nurse A was actually holding was that 1 to 1,000 30 ml vial of epinephrine. So she ended up putting that whole 30 milligrams of epinephrine into a bag of saline and was getting ready to hang that on a patient. Fortunately, someone caught that beforehand. Patient ended up not doing so well anyway, so it probably wouldn't have made that big of a difference. But again, it's one of those things where, at that point we had a 30-fold overdose of the drug in the solution, could really cause some problems, right? So you need to be very, very careful. Make sure you're being very specific about what you're talking about, especially when you're in these really hectic situations, right? Because they kind of talk about the turnaround time from the point where the provider says, I want to give this drug to this patient, to the time where it's given to the patient is never shorter than when you're in a code situation, right? So say I want to give this drug and it's given to the patient within seconds or a minute, right? Versus if you're on the floors or something, it's like I want to give this drug and it could be hours later. Okay, there's time to catch errors in that situation. Versus in a code, like you really need to make sure you're being very accurate, using the right lingo, make sure you're getting the accurate drugs in there. But again, make sure you're using the right concentrations here. It could lead to cerebrovascular accidents, hemorrhage, all kinds of bad things. And they've changed that packaging, so now they just will port out there, 0.1 ml or 0.1 milligrams per ml or 1 milligram per ml. So that'll be very much more clear on the packaging. So again, looking at endotracheal tube dosing only for when you don't have IV access available. Again, the doses are going to be much higher. So you notice here the IV dose is typically going to be multiplied by 2 to 2.5 times in order to actually get your dose. Like you see with epinephrine, it's about 10 times more. So using 0.1 mLs instead of 0.01 mLs per kilogram. And the medications you can use most commonly via the ET tube route is lean. So you can use lidocaine, epi, atropine, and naloxone. You guys remember where we use naloxone at? Yeah, overdoses of opioids. Yeah, absolutely. So, and we'll talk about where we're going to use other drugs here in just a few minutes. But again, should rarely be done, but it's good to know off the top of your head if you know, okay, we don't have IV access. How can I give this drug? Oh yeah, this is one of the ET tube ones. It's in that lean acronym. Okay, next for bradycardia, you can also use atropine. Again, this is going to be working as a muscarinic receptor antagonist. Again, it's going to be acting as a vagolytic, so basically just takes that vagal stimulation off of the heart, allows it to beat faster, have increased AV conduction, increased heart rate. This will probably be the first drug that you're going to give for a bradycardic patient in order to help kind of reverse that and speed things up. We used to use atropine during cardiac arrest, but that's been taken out of those guidelines, and now it's just strictly epinephrine for things like PEA, asystole. Really, epinephrine is just the drug to go to. So, but you can still use atropine. You'll still find it in the crash cards, but it's mainly going to be for symptomatic bradycardia. So, you see the dose here. Here you're going to notice that the max dose is a little bit lower than you see with epinephrine, so usually about 0.5 milligrams. Because again, if you give too much atropine, what problems can you run into? You guys remember the anticholinergic acronym? Mad as a hatter, red as a beet, dry as a bone, blind as a bat, heart runs alone. Right. So again, so if your patient, potentially overdo it, and then your patient's having tachycardia, perhaps they're having an increased O2 demand by the heart, maybe you're inducing an MI or something. Right. So there's lots of issues with that. So you want to make sure that we can always give more drug if we need to. We can't necessarily take it back. So usually 0.5 milligram of atropine is the max you want to use for the sake of bradycardia. All right, we'll look at the algorithms a little bit later once we kind of get through all the drugs specifically, but then next we're going to talk about the tachycardia drugs we're going to use here. So adenosine is one of the big drugs we're going to use for tachycardia. Do you guys know where we mainly use this for? Yeah, SVT, so supraventricular tachycardias, right? And so basically what this drug does is just blocks that AV nodal conduction. We talked about this a little bit when we were talking about the antiarrhythmics previously, but basically you're just kind of stopping the heart completely, and then you're allowing for kind of normal conduction cycle to start up again, right? So when you give this drug, what happens to the EKG? Yeah, it looks like a flat line, right? So you get really scared, and you're like, oh, I hope this patient comes back. I hope they come back. And okay, they came back. So, right, and it's really important to make sure you give this drug appropriately because of the fact that it has a very, very short half-life, right? This is on the order of seconds this drug's going to be sticking around for. You'll see that the dose you give is kind of escalated based on how the patient's responding. So if you give them, like, say, their first dose with like a max of 6 milligrams, they don't really respond to it. You can give them a higher dose, usually 12 milligrams. Usually you can repeat that twice in order to see if you can break the SVT and reestablish normal rhythm, right? Obviously, the patient is, this is more of like for kind of a stable patient, they're still perfusing well. If they are unstable and they are, they're hypotensive, things like that, like what do you do at that point? You guys know? Yeah. So anytime they're unstable, usually bypass the drugs, you go straight to shocking them, right? So that'd be one thing to always consider. But if you have a patient who's just feeling those palpitations, they're still awake and with it, you can give them some of this adenosine in order to help kind of restart them. So it's really, really important to make sure we're giving this appropriately. So you kind of have to have a nice little contraption set up where basically you have your drug connected. We usually use a 3-way stopcock, which you can see here. You'll have the drug connected to one end. You'll have a saline flush, usually like 10 mLs or so, connected to the other end, and then the patient's on the third end, right? So you want to make sure you're giving it very, very quickly. So I kind of push, because when we give the first dose, if it doesn't reach the heart because we didn't give it fast enough, you'll be like, well, that was ineffective. Really, the drug never really made it to a site of action. So that's why people oftentimes will give them the higher dose. Then at that point, they still have bad technique. At least some drug gets to the heart, and you maybe see some effect there. But again, you really want to make sure you're flushing immediately afterwards to get to the patient as soon as possible. The other big antiarrhythmic that we'll use most frequently is going to be amiodarone. This is a class 3 antiarrhythmic, right? So it's going to be blocking potassium channels, but amiodarone has lots of other pharmacologic actions as well, blocks calcium, sodium channels. But this is very good for a wide range of different types of arrhythmias, especially ventricular arrhythmias. So this is very, very good for that. You'll find that you can sometimes use it if the patient has SVT and they're not responsive to adenosine. Sometimes it will be responsive to amiodarone. If they have a wide complex tachycardia, or VFib, VTAC, like amiodarone is a good drug to give in all those situations, right? So you can see here that typically if you have a patient who is still, has a spontaneous circulation, they're still breathing, you want to give this not as IV push, you want to kind of give it over, a longer period of time, usually 20 to 60 minutes or so, because if you give that too fast, you'll end up seeing that you can see bradycardia, hypotension develop. If the patient's coding and they're in VFib or VTAC, you go ahead and just push the drug just to try it, because again, their circulation is going to be so poor anyway, and again, the only way they're getting drugs circulated around is how? CPR, right? So again, depending on how good your CPR is, it could be changing how good your perfusion is. So that way you just give the drug all at one time and then hopefully get circulated around to have its effect. But, and again, this is one of the big things to always remember. If you give amiodarone as a big bolus, during one of these situations, you have to, and if it's effective, you have to run a drip afterwards, because again, we're just giving them a bolus dose to get them up to a steady state, and then you have to give them a maintenance drip afterwards to make sure they maintain those levels for it to still be effective. So you can always consider adding on a drip if you have effect with the first bolus dose. Another antiarrhythmic you'll see used in the crash carts are going to be lidocaine. Again, do you guys remember where else we talked about lidocaine in this section? So it's one of the ET tube drugs. We talked about it being used as a local anesthetic. How about the first part of this section, where I'd use it for intubations?
Numbing gag reflex?
Yeah, so we use it for patients who have increased ICP, right? So if you're worried about head traumas, if you're worried about ICP issues, you give lidocaine before you do intubations, right? Kind of blunts that gag reflex, and you see less spikes in your ICP. So that's going to be one place you'll see it used in kind of code type situations. Occasionally you'll see this used as kind of a second string agent to amiodarone, because again, it works as an antiarrhythmic as well. It's a 1B antiarrhythmic, meaning it's blocking the sodium channels, and it'll be primarily used for ventricular arrhythmias. Right, so this one has a much more narrow kind of scope of what type of arrhythmias it'll treat. Amiodarone pretty much almost treats anything, right? It could be atrial, it could be ventricular, it kind of treats them all. Lidocaine here is mainly going to be used for VFib or VTAC if you're unresponsive or amiodarone is not available. Okay. So again, if you look at the ACLS guidelines, you'll find that they've kind of moved away from lidocaine. They really only mentioned amiodarone. We'll kind of look at those in just a few minutes. You do got to be careful for patients that have poor liver function, if they have renal impairment, because they can end up accumulating the drug over time. We know that leads to CNS toxicity, seizures, and whatnot. So you got to be careful with those patients. Usually end up halving the dose for them. This is another one that you give a bolus dose, and if it's responsive, you end up running a drip afterwards. So again, this is another one you can give in the ET tube if necessary, if you had to do that, but hopefully you're going to have IV access. And again, you'll see that it would be doing the fusion that ends up getting the dose cut by half approximately for patients who have hepatic disease, if they had CHF, things like that, because they're not going to be able to clear the drug as well. They're more likely to accumulate. Okay, and then we have magnesium. Magnesium is primarily kept in the code cards for treatment of torsades. So again, if you see a rhythm like this, give magnesium for it. Typically, you'll be using pretty big doses, around 2 grams as a max, in order to help kind of reverse that. The other big thing you want to be careful of is if you give it too fast, because magnesium can cause vasodilation, you can end up seeing hypotension associated with this. So it can be one thing you want to watch for, see some flushing along with it. But usually we're giving this along with fluids to make sure that they don't have too big a drop in their blood pressure. Do you guys know other situations, like in the emergency room, where you might use big doses of magnesium? Preeclampsia, yeah. So, or eclampsia, you can certainly use it there for those pregnant patients. What else? Maybe for constipation, if you're giving it mannonic hydroxide via the oral route, absolutely. Asthma is going to be the other big thing you're going to see a lot of magnesium used for, right? Because it acts as kind of a smooth muscle relaxer, it's going to work in the lungs as well. So very frequently, if we have asthmatic patients who present and they are not responding strictly just to albuterol and ipratropium, we will give them a mag bolus in order to help kind of loosen up those bronchial muscles to allow for better airflow. If that's not working, then sometimes we'll actually put them on a magnesium drip. Usually they're getting admitted at that point. But yeah, so magnesium is probably or asthma is the other big thing. You'll see magnesium being used by the IV route in the emergency room.
Is that the same thing as mag sulfate or something?
This is mag sulfate, yeah. So usually mag sulfate is going to be via the IV route. Magnesium hydroxide is the kind of oral, like, it's like green rocket kind of cure for constipation, and then mag oxide is the typical kind of like supplement that you normally just take just to replace magnesium normally. Next we have sodium bicarbonate. You guys know what we use this for?
Reverse acidosis.
For yep, so you can use it to fix acidosis, absolutely. We'll talk about hyperkalemia a little bit later, but you can use it for that, and then we actually use it for certain poisonings as well. I probably won't get just too much in depth on that, but we can sometimes use sodium bicarbonate to alkalize the blood in order to help reverse some toxicity from things like TCAs. We can sometimes actually alkalize the urine to help clear drugs a little bit faster for things like aspirin and phenobarb. But yeah, so usually you're going to be giving this if the patient's acidotic. We know all kinds of problems happen when patients get more and more acidotic. You actually find that things like alpha receptors, they change their conformation as things get more acidic in the blood, which makes your things like your vasopressors like epinephrine actually work less effectively. So this is why it's really, really important. You want to get patients bicarbonate up to alkalize and keep them at a somewhat normal pH. And what's kind of a normal pH for our patients? Yeah, 7.35, 7.45 is usually kind of a good range. But you'll see some patients, especially if they've been coding for a while, they're very hypoxic. They'll be down in like the 6.9 range. You have DKA patients, they can be down in the 6.9 kind of range. So they can get very, very acidotic and be very, very sick. We'll find some of our like toxic alcohol ingestions, like radiator fluid or something, that they get very, very acidotic as well. And so sometimes we'll give bicarb to help reverse some of that. Anywho, usually we'll give 1 ml equivalent per kilogram as an IV bolus. You'll note that there are two different concentrations that are usually available in the code card. One's a 4.2% solution and one's an 8.4% solution. Basically, we use the less concentrated form, that 4.2, to use it for infants usually, right? So it comes with a smaller package, smaller kind of pre-filled syringe. And it's really important to make sure that you have the right concentration when you're giving that dose, right? So for instance, if I want to give 1 ml equivalent per kilogram, I need to know what concentration that I'm using, because the 4.2% is actually 0.5 ml equivalents per ml versus the 8.4% is 1 ml equivalent per ml. So if I give the wrong concentration, I'm either giving a double dose or I'm giving a half dose. And that can lead to either over-alkalization or a patient not being alkalized enough, okay? So be very careful, make sure you're using the right concentration. Usually for most adult patients, they're going to get the 8.4%, but that 4.2 is reserved for the infants usually. You will see kind of a transient hypocalcemia associated with giving big boluses of sodium bicarbonate, so you may see tetany associated with that, but it's usually pretty transient. And then you'll also find that calcium is available in the code cards as well. We can use this for lots of different things. We can use it for hypocalcemia, obviously, to help reverse that. We can use it for hyperkalemia. You guys know why we use it for hyperkalemia? Actually helps to stabilize the myocardium. You'll find that in hyperkalemia, the heart's going to be more hyperexcitable, it's going to be more likely to see arrhythmias. You can give calcium, it kind of stabilizes things a little bit until you can get some other therapies on board, things like, like the bicarb, like dialysis, things like that. So calcium will be used for hyperkalemia. Why do you think we'd use it for massive transfusions?
Because of the anticoagulant in the blood.
Yeah, so again, when you're giving big transfusions, given PRBCs, usually you're going to find that in order to keep that stuff from clotting off, they have to add that citrate anticoagulant. So if you give lots of units of blood, that can end up binding up a lot of the calcium for your patient, so you can replace it when you're using that. Okay, so it's a very common one. And usually you'll find two different salt formations that are in the code card. You'll find that there's calcium gluconate and there's calcium chloride. And this is another one you want to make sure that you're, based on the dose you want to give, you want to make sure you have the right kind of calcium there. I'll show you a picture in just a second, but basically you're going to find that the conversion from calcium gluconate to calcium chloride, as far as the elemental calcium concentration, is that you have to have 3 grams of calcium gluconate to get the same amount of elemental calcium as 1 gram of calcium chloride, right? Because obviously looking at a chloride molecule versus a gluconate molecule, which one's bigger? Probably the gluconate, right? So again, you're going to find that while they both come to the same concentration, they both come in a 1 gram vial, you need 3 times as much calcium gluconate to get the same calcium as calcium chloride. Okay, that's a handy kind of conversion to keep in your mind if you're working in the ER. So The reason why they have two different salt forms there is that one, the calcium chloride, is the one you typically use if they're in the middle of a cardiac arrest. It's very, very hard on the veins, though, so we don't like to give this in the peripheral vein. If it extravasates, it can cause a lot of tissue necrosis and damage there, so we like to give this in as deep a vein as possible, usually a central line if we can make it, right? So that's usually preferred there. And calcium gluconate is a lot easier on the veins, so you can give this one in those peripheral veins, less likely to see any kind of problems with extravasation. And then obviously these are the biggest adverse effects you worry about is that thrombophlebitis and then the tissue necrosis. Obviously if the patient's got no rhythm and they're coding, we'll give calcium gluconate or calcium chloride in a peripheral vein. We'll give it via push. But if it's a patient who is somewhat with it, we will try to hold off on that. Use the gluconate instead. So you can just looking at these. As you can imagine, it'd be pretty easy to confuse these two and actually pull the wrong drug and give the wrong amount of calcium to your patient, right? Because again, they're both calcium. They both are 10% solution. They both are 10 mLs. So again, it's very, very easy to mix these two up, and so it can be another common source for medication errors, especially in kind of a hectic code situation. But if you're looking at the actual mil equivalents of calcium that's available here, you can see the concentration difference here is going to be much, much more concentrated than you would have with the calcium gluconate. Okay. And that's why the doses kind of change as well. So say like 20 milligrams per kilogram of calcium chloride versus something like 50 for calcium gluconate. So it's about a 3-to-1 conversion. Okay. Next we'll have naloxone. Obviously we already mentioned this, but this works to antagonize those opioid receptors. So it helps to reverse opioid overdoses. Does it work for any other type of drug overdoses? Sometimes we'll actually use it for clonidine. That's kind of a rare thing you might see, because again, clonidine overdoses tend to look a lot like an opioid overdose, because they come in kind of somnolent. They may have some mild respiratory depression. They usually have myotic pupils. That could all be kind of looks like an opioid. So occasionally we'll give them naloxone and actually can reverse that. I had one infant who had swallowed a clonidine patch and came in looking very much like that. And patch injections can be bad just because it's kind of a chronic release of drug throughout the entire GI tract. We ended up giving him a naloxone drip to keep him awake and kind of with it, and so that ended up working out pretty well for them. But again, usually going to be used to reverse the CNS and the respiratory depression associated with these opioids. Again, when you give this drug, you don't necessarily want your patient to be awake, right? A lot of these patients are less pleasant when they're awake than if they're just sleeping peacefully. So really just want them to be breathing, right? So again, you can look at their respiratory rate, but sometimes that can be a little bit misleading, because sometimes they can be kind of bradypneic and just not really have a good tidal volume. So in some cases you can look at their end-tidal CO2 if you have that monitoring capability to make sure they're not retaining carbon dioxide. If that's the case, then you may need to give it to reverse that, so it can help to kind of breathe some of that off a little bit better. You want to be very careful with the doses that you're giving depending on your patient, because what's the biggest side effect from giving naloxone? Yeah, you can put someone into withdrawal if they're chronically on opioids. So for instance, if I were to give a child who had never been on opioid in their life, I can give them as much naloxone as I want. It's not going to be a problem, right? Because they have nothing to withdraw from. If it's someone who has been chronic pain issues, they've been on OxyContin for decades, and I give them too much naloxone, I put them into withdrawal. It's very, very uncomfortable for them. They're going to be very, very upset. Diarrhea, nausea, vomiting, sweating, tremors, it's all bad, right? So it's not fatal like you would see with something like flumazenil, but it's very uncomfortable for the patient. So we don't like to do that if we don't have to. So you may find that for chronic opioid patients, you can start with smaller doses, say like 0.4 milligrams, see how they respond to it, and then gently titrate up. Usually 2 to 4 milligrams of naloxone is a good dose to reverse most patients. And ideally, you just want them to be breathing. You don't necessarily need them to be awake. There's also lots of different routes we can give this by. We mentioned this is one of those ones in that LEAN acronym, but I've also been finding some cases where people are putting it into nebulizers and actually allowing for patients to kind of breathe it in passively, and then as they wake up and they start to get to that point where they might be in withdrawal, they actually will pull the mask off, and then they'll kind of resedate, and then they can put it back on, and then they kind of help to titrate their dose a little bit easier by the patient rather than us giving too much of the drug. So it's kind of an interesting way you may see it being used occasionally. Okay, next we have our dextrose. So there's a couple of different concentrations you're going to find available to you. Usually in code carts and things like that, you're going to find the D25 and the D50% it's available. Do you guys remember how to get from a concentration, like a 50%, to the milligram per ml amount? Yeah, so if I had D50, how many milligrams per ml of dextrose do I have? 500, yeah, so it's 500 milligrams per ml, so basically half a gram of dextrose per ml that you're giving for D50. Obviously for D25, it's going to be 250 milligrams of dextrose. That can be important when you're trying to figure out how much you want to give to a patient. So if I'm giving half gram per kilo, I can figure out how many mLs of volume I'm going to give based on that concentration. So it's important to be able to figure that out, because obviously the D50 is going to be less volume than the D25, which is less volume than the D10. So you can kind of see some ranges here, and this is typically what we'd see like in our order sets for reversing hypoglycemia. You know, for 1 to 2 mLs per kilogram for an adult versus say 2 to 4 for the D25, which makes sense because again this is half as concentrated, so you're going to see double the dose there as far as volume goes. And then for D10, usually around 5 to 10 mLs per kilogram. You'll sometimes see this being given along with insulin, and when we talk about hyperkalemia, you'll see that. But again, if you're a hypoglycemic patient, again, anyone with altered mental status, you do want to check an AccuCheck for those patients and reverse this if necessary. The higher concentrations are going to be more irritating to the veins, so you can potentially use lower concentrations, you know, D25 potentially for younger patients. For infants, so you probably want to use the D10 because it's the most dilute, and you can have less problems with the veins. Okay, any questions from the first half? Anyone notice if any power lines were down on my car? And they were out there? Hopefully not. Okay, so we're going to continue on looking at our algorithms here. You're going to find that the PEDS ones are actually pretty similar to ACLS. Obviously, there's a lot of difference and as far as kind of what a lot of the etiologies for why a PEDS patient is coding versus like an adult patient. But as far as drugs go, it's actually very, very similar. It's just the doses are different. Do you guys know what the usual cause is for a PEDS code? Not poisoning. It's usually respiratory-wise is usually the big issue. So usually they require a lot of respiratory support. You know, so that's usually one of the big differences there. So again, with adult patients, usually it's going to be a lot more cardiac. You're going to find a lot more overdoses and things like that. It could be potentially playing a role here. It could be a lot more varied kind of thing. And do you guys know what the things you should look for as far as your differential goes? Have you ever heard of it? No, just in general for any kind of code. So you guys have heard the 7 H's and T's? Okay, so we'll cover that when you get to ACLS, but those are like kind of the most common things you're going to run into that could be the reason for why someone's coding. So you can actually find it down here on this table. So you can find reversible causes for patient coding. Obviously, I won't be asking this on a test, but just kind of good things to kind of point out. You'll be hitting this when you talk more about it later. But things like, you know, hypothermia, hyperkalemia, and things like that. But anyway, into their algorithms. First one we're going to look at is the cardiac arrest algorithm, and you'll notice it's actually pretty streamlined. This used to be a little bit more, there used to be kind of more trees, more branches to go down, but it's pretty streamlined for the most part. So obviously the first step for your patients is you're going to start CPR, right? Make sure you're give them oxygen. Make sure the airway is clear. You may need to intubate at this point, right? And then you determine whether it's going to be a shockable rhythm or not, right? And so which ones are the shockable rhythms? VFib and VTAC are the shockable ones, right? So if it's PEA or asystole, you're going to go down a different pathway where you're not shocking the patient versus if it's VFib, VTAC, you're going to be going and shocking them, okay? So anyway, so the big things you're going to be noticing here is that just down the shockable pathway, you're just constantly reassessing the patient and say, hey, do they have a shockable rhythm? If they do, go ahead and shock them. Hopefully they go back into that ROSC or that return of spontaneous circulation. If not, you just kind of continue on doing your CPR. As far as medications go, you'll notice here the epinephrine is going to be given every 3 to 5 minutes or so. Usually probably closer to 2 to 3 I end up seeing kind of clinically. But yeah, epinephrine are 3 to 5. And again, on the non-shockable side, if it's asystole, PEA, again, it's only going to be epinephrine that you're administering for these patients. The other thing you'll notice is that if you have shocked your patient a few times and they're still in VFib or VTAC, this is where you can consider using amiodarone, right? Again, lidocaine can be used if amiodarone is not available, but this is really the big one to go to if you have a ventricular arrhythmia. Amio is the big drug there. Okay, so you shock them once or twice, still not still in VFib, VTAC. This is where amiodarone can come into play. Okay. Other than that, though, it's just really just giving a ton of epinephrine. We used to have some cases where we would do a single dose of vasopressin. That's not really been found to be any more effective than giving epinephrine, so we don't do that anymore. We used to alternate epi and atropine. That's been taken off the guidelines as well, mainly because there's no actual benefit looking at that. So really, good CPR is the #1 thing to save your patient, and then you know, regular epinephrine, which even that's probably not has a ton of evidence to show it's beneficial, but it's not going to hurt the patient, right? Because they're dead anyway at this point. So we actually had a really bad case. I'll just kind of mention it here. So last Friday, I was actually kind of walking in as this patient was being moved up to the ICU. It's kind of a little sad, but again, being in Florida, what do you worry about during the summertime? Dehydration. How about a reason why a kid might be coding? Summertime, drowning, yeah. So we ended up having a near drowning case, which again, those are very, very sad cases. We actually had a patient who he was about 2, almost 2. Basically, I guess one of the back doors of their house had been open. They were watching a movie. Mom fell asleep. Kid walked out into a retention pond. Ended up being found down unknown period of time. So fortunately, the next door neighbor was a nurse, and so she was actually able to start CPR on scene, which is probably what ended up keeping the patient alive as long as the patient has been. And so they get transported to us. They end up being coded in the ER for a period of time, end up getting a pulse back. And so at that point, they were moving the kid up to the ICU. At that point, usually you're considering what kind of hypoxic injury the patient has taken to their brain. A lot of cases at that point, they're brain dead, right? They've just been down for such a long period of time that they have no brain activity whatsoever. A lot of those kids either having care withdrawn, or they end up going to like organ donations. They do like trans life, and which is a whole nother kind of can of worms at that point as far as like medications go. This patient, however, was still having some brain activity. They actually ended up initiating ECMO for this patient. You guys heard of ECMO? So ECMO, does anyone know what it stands for? Extracorporeal
membrane oxygenation.
Yes, extracorporeal membrane oxygenation, or ECMO. Essentially what that is the same thing you would do if you were putting a patient on bypass during an open heart surgery, is you're basically funneling the blood out of the patient and into a outside machine that is going to remove waste products, add oxygen back into the blood, and then put it back into the patient, right? So bypasses the lung and the heart, so that way the patient can kind of have time to kind of recuperate to some degree while we're kind of providing these extra functions for them, okay? So it's a very labor-intensive process. It requires pretty much a 24/7 team of people to be in the room. Honestly, if you ever see ECMO in practice, you're going to find there's like, it looks like almost like a sci-fi movie set or something, because there's tubes going everywhere. There's like just random blood just like being circulated around the room, and just it's kind of odd to look at. But for this patient, I was checked in on him a couple days later, and ended up he was still having some brain activity, was having still some movement when they were taking off the paralytic, and so they were still maintaining that patient on ECMO for a while. So again, sad thing. Be very careful with kids, especially with near drownings here in Florida, being an unfortunately common thing. But yeah, so that is one method we've done to try to keep this kid alive for as long as possible, give him time to kind of recuperate with the ECMO. But lots of drugs involved with ECMO. You can find a lot of heparin in order to make sure the blood does not coagulate while it's outside the patient's body and in the circuit. You have to use lots of calcium in order to replace what's being used up by the anticoagulant in the actual circuit. Obviously blood pressure control is a huge thing, so we have to use a lot of vasopressors in order to make sure the blood pressure is maintained stably. So lots of different things that go into it. So if you ever get a chance to see ECMO in action, it's pretty neat to see. But anywho, not to put a dour mood on the topic, but anyway, so again, when you're actually coding the patient, epinephrine every 3 to 5 minutes. If you have a shockable rhythm, you can shock it, and if that's not working, then amio is the drug to go to. Okay. Then moving on, looking at the tachycardia algorithms. So again, you're looking at your patient, trying to assess what type of arrhythmia they're having. Usually, if it ends up being SVT, the drug we're mainly going to go to is going to be what? Adenosine is the main one for SVT, right? Again, looking here, you're looking to see like, how unstable are they? If they are hypotensive, they're having ultramental status, signs of shock, you are still going to consider doing cardioversion. If not, though, this is where you can consider using adenosine. If it's a regular rhythm, if it's monomorphic, that one's usually the go-to drug for SVT. Otherwise, if you end up having this kind of wide QRS complex, that kind of leads you down a different pathway. So if it's regular rhythm, you can use adenosine. If it's more like irregular rhythm, it's like AFib, aflutter kind of thing, that's where you can start to consider using things like a beta blocker, potentially calcium channel blocker. What type of calcium channel blocker do you think we'd want to use in this situation? So to use like nifedipine or amlodipine? No. Yeah, so I'd want to use one that is going to be a non-dihydropyridine because it's going to be primarily working to block that AV nodal conduction, right? So verapamil, diltiazem are going to be the two big calcium channel blockers you'd use in that kind of situation. Beta blocker-wise, you can use things like esmolol, which is a good kind of short-acting IV beta blocker. It's very titratable because it is so short-acting, so you can kind of give them a bolus, hopefully that gets the tachycardia under control, and then kind of run a continuous fusion afterwards. Sometimes labetalol and things like that can be used until you can transition the patient over to oral therapy, right? So again, if it's regular, it's SDT, you can go ahead and use adenosine to try to reverse that. Otherwise, if it's irregular, wide QRS complex, you can end up using beta blockers and calcium channel blockers. Okay, and then for bradycardia, here the biggest thing you're going to be using is probably going to be atropine. So again, this is kind of your first stop for kind of reversing that, trying to increase the heart rate. Potentially, you can also use things like transcutaneous pacing, but just focusing on the meds here. Atropine's the first stop, and then potentially you can use a few other drugs. So you can use things like epinephrine as an infusion. You can also use a drug called dopamine. I'm going to have a section on vasopressors in just a few minutes here. But basically, you can use anything that has kind of pro-cardiac effects. It can be positive chronotrope, positive inotrope, in order to help reverse that bradycardia and increase that cardiac output. Okay, so atropine's the first drug you're going to give, and then potentially either like a dopamine or an epinephrine infusion. Okay, so again, when you have an adult code, everything is, a lot of people have practiced running adult codes. It's usually pretty well-oiled machine, things being done pretty consistently. When you get to peds, especially if you're in a adult hospital and you get a peds code, it is utter bedlam. It is chaos. No one knows exactly what to do. Everyone's freaked out. It's really, really important to know your resources. And so very frequently, you either have like code sheets that are available to you. They'll actually be segregated based on weight. So you can look at say I have a 10-kilo kid who's coding, these are the doses and the mLs and the volume of drug I need to give for that patient. So that can be very, very useful, especially for resuscitation meds, for intubation meds. So if you have that available, that can be very helpful. You don't have to do calculations. So again, if I'm trying to figure out, I have a 12-kilo kid and I need to give 0.01 mLs per kilo of epinephrine, doing that kind of math when the kid's like dead in front of you, it can be very difficult, right? So that's why having these code sheets is very useful, because you can say, okay, I need to give 1.2 mLs. I'm going to give that to the patient right now, right? So it helps speed up the whole process. If you find that patients are kind of between weights, you can always round up. It's always a little bit better to give a little extra meds in these kind of situations and not give enough. Here's an example of like what our code book looks like at Nemours. So for instance, we have a 10-kilogram patient here. You can even find we'll have like defibrillation doses, actual how many joules we're going to program in for that patient. And then you'll have things like, adenosine. Okay, here's the route we're going to give it. Here's the dose I want to administer based on it being a 10-kilogram patient. And then here's the volume, right? Because we don't really care what the milligram amount is. Like the nurse wants to know how much volume I need to infuse into this patient to get the dose in, right? So it can be very useful to have all this available just at your fingertips. What it would look like for the rapid sequence intubation meds. Here you see we use etomidate and succinylcholine as kind of our go-to drugs. Here you have your pre-medications, the atropine and lidocaine. Again, when do you think you'd want to use atropine? So if they're already bradycardic, you want to consider using atropine, right? Because again, doing that laryngoscopy can lead to increased vagal tone, drop your heart rate. If the patient's getting repeated doses of succinylcholine, that can also lead to bradycardia, so you can give it to reverse that. Those are the most common ones. And then, for instance, that would be down in the emergency department, but if you're like up in the ICU, they use a different set of meds. So they use things like fentanyl, Versed, sometimes use propofol, and then even rocuronium, which is what type of drug? The paralytic. What type of paralytic? Next gen. It's non-depolarizing neuromuscular blocker, right? You want to be able to delineate the depolarizing versus non-depolarizing, because it's going to be much different patients in which you can use those drugs safely. Okay, you guys ever heard of the Broselow tape? So Broselow tape is a very common thing. I actually worked with one of the docs who helped to develop the system. There's Dr. Luton, who's the other person who helped develop a lot of this. He's actually an attending over at the UF Shands in Jacksonville peds ER over there. But essentially, this is a very common way. There's probably some other methods that are out there now, but you'll still see a lot of Broselow tapes being used pretty commonly. Basically, what you end up doing is you'd lay the kid out on the stretcher, and then you'd have the one end of the tape here at the head of the child, and then you would basically see where, based on their length, what color they fall into. So for instance, this kid would probably end up being a yellow, and so based on yellow, you can estimate that they're between 12 and 14 kilograms, and then you basically have a sheet that would tell you all your drug doses at that point, right? So that was another way that they could very quickly assess the patient. If you didn't have time to get a weight, you could figure out what type of doses to give to, because again, adult patients, you're giving them all the same doses, it doesn't really matter. But for kids, they're not just little adults, you need to kind of tailor the doses to their weight specifically. Do you guys see any shortcomings with using this method? Yeah, so really underweight kids or really obese kids can be problematic. So you may be giving under or overdosing the patients. Also, what happens if you accidentally flip the tape around? If you have someone who's inexperienced or they're very nervous about dealing with the PEDS code and they put the wrong end on there, right? It actually tells you, say, hey, here's the red to head, but if you're freaked out, you might put it backwards or something, and then you have the wrong color you're using, right? So then all of a sudden you think it's a 30 kilo kid versus 12 kilo. Okay, so that can be problematic. So just make sure the patient or the people get practice with it. They do sims and things like that to help them make sure they're using it right. Okay. Oh, one kind of funny things you don't think about until you're actually working in a hospital and you're actually helping, especially to open up a hospital. One of the things that they purchased at Nemours was beds in the trauma rooms that actually had scales already built into them, right? So that way, if you brought the patient in, you could lay them on there, get the weight, and you automatically knew what was going on, right? One of the things they did not consider is what the weight tolerances on the beds are, right? So if it's an adult bed, guess what? It's only accurate down to 50 kilograms. So at that point, you measure, an infant comes in and they're only 4 kilograms. Is that actually that accurate? What's the variances on that, right? So you have to consider things like that. Well, how accurate are you actually measuring this patient's weight? Because that can have huge differences. And I mean, we get very, very tiny babies on that bed, and that we need to give doses to. So it's one of those things we want to make sure you're doing it accurately. So anywho, Nemours is a very safe place to go to. I would take my kid there, but just little things that you don't think about until you're actually opening a hospital, right? So anyway, other tips to have a safe resuscitative experience, make sure you always have callback going on, right? So if the doc is running it and say, hey, give me a dose of epinephrine, you say, okay, well, what dose of epinephrine would you like? And then, if you were to draw it up or whoever's drawing it up, they say, okay, I have 0.3 milligrams of epinephrine. We're going to give this IV. You hand it off to the nurse. They directly say, okay, I have 0.3 milligrams of epinephrine. That way, multiple people are hearing it. They can all say, hey, that sounds like the right dose. Or they can say, whoa, whoa. That sounds wrong. You just said 3 milligrams of epinephrine. That's not right. And they can figure out what's going on there. Because again, it's a very, very tight time frame from when someone has an idea of I want to give this med to when it's actually given. You want to be able to capture those errors if you can. Also be very precise. You'll hear very often, I gave an amp of calcium or I gave an amp of dextrose. That doesn't tell me anything, right? Because if I gave an amp of D25 versus D50, that's either doubling or halving on the dose that I wanted, right? So if you say, hey, I gave 25 grams of dextrose, or I gave 12.5 grams, or I gave 1 gram of calcium chloride, right? Because if you just say calcium, is that calcium gluconate? Is that calcium chloride? Who knows? And then you always want to make sure you're using your units. So for instance, if you say start dopamine at 5, a lot of people would know that means 5 mics per kilo per minute, but if they program it into the pump wrong, they can get the very wrong dose. So a good example of this, we had a patient who was coming in for an NSTEMI. Basically, they're having continued chest pain, so we ended up putting them on a nitroglycerin drip. And so they said, hey, give the patient, start the nitro drip at 20. And so they thought they were, what they should have put it in as was mics per minute. They ended up putting it as mics per kilo per minute. So when you multiply that out by the patient's weight, the patient is getting a whole bottle of nitroglycerin in about 10 minutes. Okay, so it's very, very easy to make those kind of errors if you don't keep it straight with your units. Okay, patient ended up doing okay in that situation, but I had a very, very bad headache after all that nitroglycerin. Okay, so any questions on the ACLS stuff? Okay, moving on, we're going to talk about chronotropes, inotropes, and vasopressors. Cardiac miscellaneous meds you might use either in the ED or in the ICU type setting. So obviously chronotropes are going to be drugs that are increasing the speed of our heart contractions. Our inotropes are just going to be increasing contractility. And then our vasopressors are specifically meant to increase this peripheral vascular resistance. Okay, you're going to find that you can have drugs that can fulfill multiple roles out of here. You can have drugs that are positive inotropes and chronotropes, or you can have drugs that are positive chronotropes and vasopressors. So we'll look at some of those and how, what situations it might be best used in. So the first one, this is a pretty typical one you're going to run into, is going to be dopamine. Again, this is acting very similar to the endogenous dopamine in your body, and it works as a precursor to developing things like epinephrine and norepinephrine, right? So dopamine, to have a lot of its effects, has to be converted over into epinephrine and norepi to have those effects. You're going to find that the effects that you get from dopamine depend on what dose you're running the infusion at. So you can find that low dose dopamine is primarily going to be affecting dopamine receptors. Okay, that primarily means it's going to be helping to increase renal blood flow and actually improves urine output. You don't really use dopamine at this dose range very frequently, because usually when we're giving it, patients having poor cardiac output, they're hypotensive, we want to fix that. So you'll either use kind of the medium range or intermediate range dopamine from 5 to 10 mics per kilo per minute. Notice the ranges there is mics per kilo per minute, not like per hour, so you can avoid some errors by doing that. Here you're going to find it's going to be more effects on the beta receptors. So it's going to have positive effects on the heart rate. You're going to see better contractility out of the heart, primarily because it's affecting those beta receptors. Okay. If you go even higher doses than that, above 10 mics per kilo per minute, you're going to start to have more alpha effects as well. Okay, so now you can start to see increases in blood pressure along with positive effects on the cardiac output. Okay, so for instance, if I had a patient who is, say they come into the ED, we resuscitate them, give them some fluids, and they are bradycardic still, but their blood pressure is looking okay, I might put them on the intermediate range dopamine, right? Versus if they have poor cardiac output and they're hypotensive, I'll put them on the higher range dopamine. Most patients usually end up getting put on the higher range. Usually start at 10, and then you can titrate it based on how they're responding. Okay, you guys know what we normally titrate their blood pressure to? Usually it's like a map of 65, right? So mean arterial pressure of 65 is usually a pretty good range of where most people will put their titration orders for a lot of these drips. So a lot of these adverse effects are going to be related back to the specific mechanisms we're seeing here on the different receptors. And so you'll see a lot of these side effects are going to be prevalent amongst all of the vasopressors we're going to be talking about. But basically, you want to make sure that whenever you're giving vasopressors, the patient is good intravascular volume. So you really want to make sure they have fluids on board before you start your vasopressors. Because again, if you're squeezing down on the vessels and there's nothing in there, you're going to have a hard time increasing your pressures, right? So you want to make sure you give fluids first, generally with some IV crystalloids. What are some examples of IV crystalloids? Normal saline, lactated ringers, yeah, so those are the most common ones you're going to run into, right? So usually we're end up using IV crystalloids, give them a couple liters of saline, kind of beef them back up from that standpoint, and then you can start your vasopressors if they're still hypotensive. When you have excessive beta stimulation, you run the risk of having obviously tachycardia, but you can also have arrhythmias. So all of these drugs that are positive chronotropes, inotropes, they can lead to arrhythmias. Okay. PVCs are probably the most common thing you're going to run into. There's premature ventricular contractions. You can feel palpitations, but there is always a risk, especially for those kind of high-risk cardiac patients. They can develop things like ventricular arrhythmias. So always be wary about that, especially the higher doses that you're running here. You don't want to run your dopamine doses too high. If you start to get above things like 20 mics per kilo per minute, this is where you start to see more of the kind of splanchnic vasoconstriction. And anytime you're having these vasopressors on board, you're going to be seeing that it's going to limit blood flow to some of the kind of secondary organs, right? So you can see renal hypoperfusion potentially. So you can actually see acute kidney injury related to having too many vasopressors on board and reducing that renal blood flow, right? I mentioned dopamine at low doses can actually increase that, but at higher doses you lose that dopamine effect, and it's really just more the alpha effect you're looking at there. So be careful with that. Again, alpha stimulation, you can see things like the cold extremities, chest pain associated with that as well. So again, all goes back to the alpha stimulation. And then with any of these vasopressors, if you have extravasation, that can be leading to tissue necrosis, because again, it's just causing way too much constriction there, decreasing the amount of oxygen getting to the tissue. And so we can reverse that with an alpha blocker called phentolamine. Okay, so we can administer that in order to help reverse some of the local vasoconstrictive effects. Okay, so the next one that we use very frequently is called epinephrine. Now we mentioned this as giving kind of intermittent doses of it for someone who's in cardiac arrest. We know there's lots of other uses for it. You can have inhaled epinephrine that we use in things like croup to help kind of decrease the kind of airway resistance. Use it topically, for vasoconstrictive needs, especially with like local anesthetics. And also intramuscular. So where do you see a lot of intramuscular injections of epinephrine? Yeah, anaphylaxis, so a lot of EpiPens, and again, this can be another reason why you might see accidental injections. So we get calls to the poison centers with some regularity from people who accidentally inject themselves with their EpiPen in the finger. Obviously, that's going to cause a lot of vasoconstriction, so you can start to see that it gets kind of gets very pale, gets cold. So sometimes we actually have to use phentolamine in the digit in order to help reverse that. So it can again be another case where you see someone coming in for accidental exposure to these meds. But anyway, when it's used as a vasopressor, you're going to find that epinephrine has a very balanced effect on both the alpha and the beta receptors. Okay, so if your patient is bradycardic, hypotensive, this is a great drug for them to help kind of beef up both of those aspects of it. So positive contractility, positive effects on the peripheral resistance. And again, similar side effects to what we saw with the dopamine. Again, alpha effects, you can see decreased perfusion to certain organs. With the beta effects, more risk for arrhythmias, and also extravasation problems as well. One drug that is a purely beta-1 agonist is going to be dobutamine, or Wtrex. This one is only a positive inotrope. Okay, so this is good for patients who have, say, like decompensated CHF. If you need to increase their cardiac output, dobutamine is a good drug to use for those patients. Biggest problem you're going to run into it is going to be the fact that it's arrhythmogenic. Tachycardia, PVCs are all going to be possible here. They've also seen the kind of long-term use of these kind of positive inotropes for your CHF patients actually leads to probably a worsened mortality. So really only for short-term use is decompensated, acute decompensations of CHF. Along the same line of beta-1 agonists, you have isoproterenol. This was an older drug that's been mostly replaced by dobutamine, but we will sometimes still see it used. Like we use it over at Nemours for our cardiac clinic. They'll sometimes use it for like tilt table testing and things like that. So occasionally you might run into this one. It's actually very, very expensive. It's like, even though it's super old, it doesn't get used very frequently. So it's like thousands and thousands of dollars for like a single dose of this, which really makes no sense. But that's drug companies for you. Next we have milrinone. This is Primacor. You'll sometimes again see this used for acute decompensations of CHF. This one's kind of interesting because as opposed to like dobutamine, which is a pure beta agonist, you're really only going to see effects on the heart. This one actually is a positive inotrope, and it's also going to be a vasodilator. Right, so if your patients had a lot of afterload problems, this can actually help to decrease their blood pressure, help the vasodilate, and improve perfusion for your patients. It does this by acting as a phosphodiesterase 3 inhibitor. Remember where else we saw phosphodiesterase inhibitors?
Viagra.
Yeah, Viagra and other menstrual erectile dysfunction. So this one specifically affects PDE3 instead of PDE5. So that's why it has more kind of vascular effects than what you saw with like Viagra, working with the lungs from that standpoint. So again, we do see increased risk for arrhythmias with this drug due to that positive inotropic effect there. So it is one thing you want to be watching for. And then obviously it can cause hypotension as well. So again, if your patient's already hypotensive to begin with and they have poor cardiac output, this is not a good drug to get. Dobutamine might be a better choice for them, or isoproterenol potentially. Okay, next we have norepinephrine. Brand name is Levophed. You guys know what they used to call this drug? It's called Leave 'em Dead. This used to be a last line, like the patient's going to die anyway, let's go ahead and just try something. But nowadays it's actually getting much more use as a first-line vasopressor. So dopamine used to be kind of like the go-to vasopressor for a lot of people. Nowadays norepi is becoming more preferred. Basically this is the same as the endogenous catecholamine we all produce already, but the nice thing here is that it has good alpha effects. It still has some beta activity, but it's going to be more primarily increasing that systemic vascular resistance. So this is really, really good for patients who say come in with septic shock, right? So the cardiac output is probably okay. If anything, they're tachycardic because they're so hypotensive. This is good because you can give it to increase that squeeze on the vessels, increase their blood pressure, and kind of help to decrease that heart rate as well. So this is a good, again, epinephrine being a little bit more balanced equally between alpha and beta. This one is primarily more affecting the alpha receptors, so very good for hypotensive patients. We use this one almost exclusively for our patients who like overdose on beta blockers or calcium channel blockers. This is always our go-to drug. And then you have phenylephrine, which is just a pure alpha agonist. Again, phenylephrine, you're going to see this used obviously orally. You can see a lot of cough and cold preparations, topically for things like nasal administration. But here we're giving it parenterally to cause the vasopressor effects. Obviously, this one, because it is a pure alpha agonist, you do worry about perfusion to certain organs, worry about cold extremities and things like that. This is usually used as an add-on to other vasopressors. So you'll run into some patients who, if they're on dopamine or on norepi, and they're really not getting as much squeeze as they need, they will add on a different vasopressor. So usually phenylephrine gets added on, and one other one we'll talk about in just a few minutes. But again, not first line, but it could be good if you have a patient who's just has a kind of isolated hypotension. The other one we can potentially use is going to be vasopressin or pitressin. You guys know this one is antidiuretic hormone. We've talked about other varieties of it previously, so DDAVP. You guys remember where we talked about that at? Yeah, for diabetes insipidus was the other place we talked about that one. So again, DDAVP has kind of replaced vasopressin for use for things like esophageal varices, diabetes insipidus, but we still use vasopressin IV for purposes of maintaining blood pressure. You will most often see this in patients who are in septic shock. Usually they have an issue where they are kind of so metabolically, just stressed out. They run out of a lot of these stress hormones and things like that. So we can actually use vasopressin to help with the third spacing of fluids that they're having, right? Because they have a lot of leaky capillaries. They're losing a lot of fluids out of the vessels. This helps as an antidiuretic hormone help hold on to more of that water, help more hold on to more of that salt. And so this is a very good adjunctive agent to things like norepinephrine. For instance, you have a septic patient coming in, you'll start them on norepi, and then you may add on vasopressin if they're still having issues with their blood pressure. This one used to be given as a single dose and during ACLS, but that's no longer recommended. So if you ever hear that, it's kind of an old recommendation. And for the most part, it's pretty well tolerated. You're going to see obviously some risk for things like water intoxication because it is antidiuretic hormone. They're going to want to drink water, but a lot of these patients are going to be so sick from other reasons they might be intubated. It's not really going to be a big issue. Okay, so then again, how do you pick your agent? It's based on the patient condition, right? So you're looking at things like poor cardiac output, whether SVR is okay. Things that are primarily working on the heart are going to be better here. So things like isoproterenol, dobutamine, that intermediate dose dopamine is going to be useful here, okay? Say they have cardiac output and their systemic vascular resistance diminished. That's where things like high dose dopamine, that above 10 mics per kilo per minute, norepi or epi are going to be good options for those patients. And then if they have diminished SVR, but their cardiac output's okay, at that point we can use things like norepinephrine or phenylephrine because they're going to have a lot more of the alpha effects. So for instance, we had a patient who had overdosed on minoxidil. You guys know what minoxidil is? Rogaine, yeah. So Rogaine is a very potent vasodilator. So we had a patient who had overdosed on that. Basically, he's trying to get the alcohol content because Rogaine's like 11% by volume alcohol. So he was out of alcohol and drank all that. But it came with just profound hypotension, very tachycardic, trying to kind of keep up with that. And so we ended up using just phenylephrine on that patient. He ended up having required a few other vasopressors, but phenylephrine is our go-to for that one because we knew the issue was vasodilation. So let's fix that by just having alpha constriction. So that's why I use phenylephrine there. And again, septic patients very frequently need vasopressin added on to help control their blood pressure. Okay, so any questions on those drugs? All right, continuing on with hyperkalemia. So we know potassium is primarily sequestered in the intracellular space, right? So about 98% of potassium resides within the cells versus the 2% kind of floating out in your bloodstream. Your normal kind of potassium range is what? Don't look at the slide. Yeah, you're around 4, like 3.5 to 5 usually is considered to be kind of a normal potassium. And so again, it's almost entirely excreted by the kidneys. So you're going to find that a lot of renal patients have issues with hyperkalemia. There's going to be lots of other reasons why you see potassium levels going to be increased here. But renal dysfunction can be a big issue here. Increased intake of potassium. So if they use like salt replacements and they're using potassium-based salts, you can see issues with hyperkalemia there. And then also ACE inhibitors, NSAIDs. Those all can lead to increased potassium levels for especially the renal patients. You're going to definitely see big issues with that. The problem here is going to be mostly cardiac in nature. You can see things like slowed ventricular conduction, shortening of action potentials, and you can worry about things like VFib and asystole developing. Okay, so these patients have really elevated potassium, things like, they start getting the 6, 7 range. You start to get concerned about these cardiac arrhythmias, but peripherally you can also see some of these paresthesias and weaknesses as well. And so we want to reverse this because this is definitely potentially life-threatening. So how do we do this? I have a handy mnemonic to remember the treatments to use for hyperkalemia because not all of them are very intuitive when you're looking at them. But basically I use the mnemonic CA big K drop. Okay, basically it's going to stand for calcium, albuterol, bicarbonate, insulin, glucose, K-exalate, and then dialysis. Okay, I'm going to talk about one of those in detail in just a second here. So the reason why we give calcium is it helps to stabilize the myocardium. Basically, it helps to reduce that threshold for having an action potential and helps to maintain a normal rhythm for a longer period of time in the setting of hyperkalemia. So you can find that this is mostly beneficial in patients, even if they're normal calcemic, even if they have a totally normal ionized calcium, you can still give them exogenous calcium, give them extra to kind of boost them up and help maintain that maintain a stabilized myocardium. You'll find that this is kind of a short-term countermeasure, only lasts for about 30 to 60 minutes or so, but this can be good while you're getting other therapies on board. So this is usually one of the first things that we give. And again, you can give calcium chloride, you can give calcium gluconate. Gluconate's a little bit easier on the veins, and a lot of these patients are still kind of with it enough that you can give them calcium gluconate. Again, what's the conversion of the dose between chloride to gluconate? 3 to 1. Yeah, so I need to give 3 times as much calcium gluconate to get the same amount of calcium as calcium chloride. Okay, so just kind of remember that conversion. Next, we want to use some medications that can help to shift potassium into the cells, right? So we can use things, instead of getting rid of them out of the body, we can just shift them in intracellularly, temporarily, and that can help to reduce that stress on the heart. So things we can use include beta receptor agonists. So you can do things, especially if you don't have IV access, you can use inhaled albuterol. Could be one thing we can use. You can also use terbutaline. You guys remember where we used terbutaline previously? To prevent contractions for pregnant women. If you go back and look at that one, but basically because it acts as kind of a smooth muscle relaxer for those, but also when you activate these beta receptors, you see intracellular shifts with potassium. So that can be useful if your patient's sitting at a potassium of say 7 and you can get them down to say 6.5. That could be decreases that risk that much of having an arrhythmia. So again, we will do this. Sometimes you'll see albuterol given via continuous nebulizations. They're just kind of constantly getting that dose there. Very frequently, you're going to see tachycardia and tremor associated with it. So just know those are common side effects there. And note that patients who are on beta blockers are actually more resistant to this, right? Because those beta receptors already occupied. You may see less effect from things like albuterol and terbutaline. Okay, and then the other thing we can do to shift the potassium intracellularly is going to be bicarbonate. This is going to be most beneficial for acidotic patients. You find that as the pH of the blood drops anyway, you're going to find a natural shift of potassium out of the cells. This helps to drive them back in. So again, same doses we would use for like a code, 1 milliequivalent per kilo IV. And then the other way we can shift potassium into the cells is going to be with insulin and glucose, right? So this helps to drive, because again, normally insulin is an anabolic hormone. It's helping to drive things like carbohydrates and drive other kind of nutrients and things into the cells. This is the same thing with potassium. So we can actually give 10 units of regular insulin. No, it's regular insulin, not any other types of insulin, along with dextrose, and that will help to drive some of the potassium into the cells. Right. Sometimes you may need a dextrose infusion afterwards, depending on how sensitive they are to the insulin, but it could be one thing you may or may not need. Okay. So we're finding ways to stabilize the myocardium. We shifted potassium into the cells, right, which is just a temporary fix, because as soon as they come back out, the patient's going to be hyperkalemic again. The next question is, how do we get it off of the body? Right, so a couple ways you can do that. Diuretics are really going to be kind of plus minus. Don't really get a lot of consistent benefit out of using that. So instead, what we can use is an exchange resin. So we have a drug called sodium polystyrene sulfonate, or K-exolate. Kind of remember what the drug does based on the brain name. So K-exolate, kind of getting rid of potassium. Essentially, it's a resin that will exchange sodium for potassium. Okay, you can administer this orally. In emergent cases, we'll actually administer this rectally. So we'll kind of give like an enema of K-exolate, and it's going to help to shift sodium, absorb that, and then we'll have kind of like a gut dialysis and pull potassium off the bloodstream onto the K-exolate, and then it'll just be eliminated through the feces. Okay. Constipation is very common with this one, but again, you can kind of figure that out after you get the hyperkalemia kind of fixed. Again, that's a slower process than the ultimate kind of therapy, which is going to be dialysis. Okay, dialysis is kind of the end goal for a lot of these patients. A lot of them are already going to be dialysis patients anyway, so they may already have fistulas in place, which can make your access that much easier. And usually after 1 or 2 hours of dialysis, you already can see a 1 to 2 milliequivalent drop of potassium. So again, pretty rapid correction of that. And again, that's going to be kind of the ultimate therapy. But if it's more kind of a non-emergent case, something like K-exolate can be useful in the meantime, right? So any questions on hyperkalemia? Okay, and then just real covered anaphylaxis previously, but what are some of the meds we use for treating an anaphylactic patient? Use steroids. What type of steroids can we use? Solumedrol is a good one, right? We don't like Depomedrol because that's going to be a more long-acting formulation. We want fast-acting. So Solumedrol, which is what drug? Yeah, methylprednisolone. What else can we use? Prednisone. That's usually for like more minor cases of allergy because again, it's an oral drug, so it takes a little bit longer to get absorbed. But methylpred's a good like IV kind of agent, or IM. Dexamethasone's another good one. Potentially hydrocortisone. Yeah, some people will go towards hydrocortisone as their kind of go-to. I see a lot more methylpred use in the ER. It doesn't really matter which one you use. And again, what's kind of the onset of action for the steroids? Yeah, it's slower, right? So it takes time for the steroids to really kick in because, again, they're changing things like gene transcription and whatnot. They have to get into the nucleus of the cells to have their site of action. So those are going to be good to get on board, but in the immediate life-threatening kind of time frame, like those are not going to be super useful, right? They're going to be better for especially those kind of late stages of anaphylaxis. And in the meantime, though, what else can we give?
Epi.
You give epi, so we give epinephrine. How do we normally give that? Yeah, usually IM. In some cases, especially if they're in like anaphylactic shock, you can give it IV potentially. So keep that in mind. But usually IM is a good way to go. You guys know the dose by any chance? Don't want to give 1 milligram. So again, that's like for cardiac arrest, like the patient's already dead. Patient would be feeling very, very bad if you gave him 1 milligram. Usually like 0.3 milligrams is usual like EpiPen dose. EpiPen Junior is like 0.15. So that's again, I'm not going to ask it on the test, but just for your reference. Okay, so we got Epi on board. That's going to do what for us? It's a vasoconstrictor. It helps as a bronchodilator. It can be useful. Helps reduce a lot of that edema and swelling we see there, right? So that's going to be one of the most life-threatening or life-saving medications we can give. What else can we use? Antihistamines, right? So they're going to be the other factor of that. So again, H1 antagonists are the most important thing to add on here. So things like diphenhydramine, hydroxyzine. Diphenhydramine is probably the most commonly one used IV for severe anaphylaxis, but really any of them could work. In some cases, I've actually seen for more mild allergic reactions, some people are trying to use cetirizine. It's good for more kind of peripheral effects, but again, it's really from the most mild cases. If they're having true anaphylaxis, IV diphenhydramine is going to be the way to go with that one, right? And then sometimes they'll use H2 antagonists, so they'll add on things like ranitidine, just because if you're having a lot of histamine release, you can see a lot of GI effects from that, increasing gastric acid secretion, so you can add on things like Zantac to help prevent any kind of GI effects from occurring. So again, good. So those are the most common measures we give for anaphylaxis. This is going to be the number one thing we need to give. And then the steroids take time to work. So again, it's going to be better for kind of late stage effects. Really the best thing to do is get Epi on board early. Okay. So any questions on emergency medicine stuff? And kind of a smattering of topics, try to hit where the new drugs were. If not, there's no questions, and we'll continue on with talks on Tuesday.